Pattaya City Expats Club is a non-profit social organisation and our speakers are volunteers. The club as such assumes no responsibility or liability for the professional reputation of or the quality of services provided by the speaker today.
This week's speaker, sitting there looking very nervous, is Dr. Tanarat. He's going to speak on the topic of avoiding and overcoming foot problems and pain. He's actually an orthopedic surgeon at Bangkok Hospital Pattaya, and he specialises in foot and ankle surgery. And he'll be discussing various things that you can do yourself, such as stretching and appropriate shoes for certain activities to help you avoid those problems. So, with no further ado, would you like to give Dr. Tanarat a warm PCEC welcome?
Hello. Good morning, all audience. I'm Dr. Tanarat Hempongphan. My specialty is foot and ankle surgery, and today thank you the Expat Club to give me an occasion to stand here. Today we focus about foot and ankle problems. Before we discuss about the disease and any problems in foot and ankle problems, in the first part I will start with the basic anatomy of the bone in foot and ankle. This picture shows the bone anatomy. The ankle is composed of a tibia and fibula bone, and it's combined to be a socket. And inside the socket is the talus bone, which is the center of the ankle joint. And below the ankle is the foot. From the back, we call it high foot. And below the talus is the heel bone, or its name is calcaneus bone. Next to the midfoot, which composed of the bone look like a board, is a navicular bone. And next to the navicular bone is cuneiform 1, 2, and 3, and the metatarsus, the first to the fifth. And the soft tissue structure on the outer side is important because when you have ankle sprain, lateral ligament is the organ which is dislocated first. And back to the lateral ligament is the peroneal tendon. Above the joint, the space between tibia and fibula is syndesmosis. And the dislocate to the syndesmosis now we call is the high ankle sprain, which is the most common problem for the chronic ankle sprain. And at the midfoot area, we have the wrist sponge joint and ligament, which give the connection of the forefoot and midfoot. And next is the inner side, the deltoid ligament and tibialis posterior tendon is an important organ in the flat foot. And at the back of the calcaneus is the Achilles tendon, which is the most strongest tendon in the human body. And below the calcaneus, we have a band-like structure. It's a plantar fascia, which is the very common problem of the heel pain. And did you know what are the three most common problems of the foot and ankle in our patient clinic? I come from my experience in Bangkok Hospital. The first most common is the ankle sprain. The second is the heel pain, which is a plantar fasciitis. And the third one is the gastrocnemius tightness. I think many patients have the gastrocnemius tightness. It's maybe you can come with the cramping of the leg. And I think it's important. You should know about the initial treatment like a basic exercise, or when you should go to the hospital to seek the treatment. And next part I will talk about the case-based presentation. to give you guys the example of the case and what kind of the treatment I recommend. I have no disclosure of any benefit from the company and the hospital. And all of case picture in this presentation are my real patients. And I'm a surgeon, and if some picture make you scared, I'm so sorry about it. Forgive me. Okay. For easy to catch up, I divide the patient into two groups. The first group is the trauma group, such as the fractures or major injury to the foot and ankle. In the first case, is a female, 40 years, with a twisting injury. You can see that there's a fracture at the fibula bone. It is a simple fracture. You can know that the simple fractures or not. So, to be the best result for these fractures, in the past, we believe that we fix the bone, it's finished. But nowadays we know about the anatomy with the many X-ray alignment that clue us about the soft tissue injury around foot and ankle. In this case, I pay attention at the incongruent joint and soft tissue between tibia and the fibula. If you can remember, it's called the syndesmosis. And the ligament at the inner side, or the deltoid ligament. So in this patient, I send the patient to do the MRI first. So in this case, I decide to fix all the bone fragment and the ligament by the standard method for the syndesmosis and the deltoid ligament repair, not only the bone. So, and the next case is the difficult fractures in the Bangkok Hospital. I'm not sure that the patient is here or not. It's a 65 years old male with a fracture dislocation of the midfoot. So we do open reduction. We do the big incision because we need to reduction all of the joint and internal fixation with rigid and mobile fixation. Next case is 50 years old male came to see me because of he lost of plantar flexion power of the left ankle, but he still can walk. From the MRI, does anyone know that what is the diagnosis of this patient? As you can see, the white one inside is a ruptured Achilles tendon with a large gap about 7 centimeters. But he can walk. With the large gap to regain the length of the Achilles tendon, we need to make sure that after repair, we will have the secure construct, which could do the every range of motion exercise. And he needs a special technique for this case. And this video shows the 6 weeks after operation. He can walk with a feeling of 90% before injury. And the next part is the disease. Disease for the aging population. In this part of the patient will fail to the conservative treatment about more than 6 months. If you can remember that ankle sprain is occurred at the lateral ligament, ankle sprain have many grades. I normally use grade 1, 2, and 3 for grading severity to communicate with the patient because grade 1, 2, and 3 have the different consequence after treatment. Grade 1 is simple. You can walk with a little pain, mild swollen, but you can walk. And the grade 2 is a subachymosis and swollen, difficult to walk. And grade 3 is hard to tell that you have fracture or not because it's too much pain, really pain and swollen. In my practice, I give the solid splint, such as a posterior slab, for both grade 2 and 3 because at the short time stabilization for the torn ligament is better healing more than left it free. Only grade 1 is freely walking. So for conclusion for the acute ankle sprain, if you suspected of grade 2 or 3 ankle sprain, please come to see the treatment at the hospital. But what happens if the ankle sprain is not healed for more than 2 or 3 months? In this situation, we need to find out that first, is this a true ankle sprain, not other ligament or the cartilage injury? And the second, why is not healed like other? Do you have any avulsion fragment of the ligament or not? And 3, what is the next step of the treatment? It depends on the physical examination, and in some cases, you need to do MRI to confirm the diagnosis before definite treatment. In the instability case, if you feel pain more than 3 months and you feel like instability, it means multiple times of ankle sprain, easy to sprain. We do direct repair or reconstruction of the lateral ligament. Mostly I do the arthroscopic examination before repair ligament because I found that many cases we have a problem inside the ankle, not only the ligament. And this picture is staff in the hospital. I asked her for permission to use her picture. Next slide. The next case is a 42 years old female. She is my sister. She has a low energy twisting injury at the ankle. But she skipped the x-ray for 6 weeks because she told me that she has only pain and swollen. Not too much pain, she can walk. In this case, we call it a stress fracture. And we need to know that the cause of the poor bone quality of this patient. Finally, we found that she has a hypovitamin D level. Her vitamin D level in the blood is very low, and is the cause of the stress fracture. In this case, we do the fixation of the bone and seal the bone gap with the bone graft, and also correct her vitamin D level at the same time. Same to the knee osteoarthritis. Anyone know about knee, OA knee, osteoarthritis of the knee? But this is occurred at the ankle. It's called the ankle arthritis. This can be aging change or the post-traumatic change or after accident. In this kind of case, we select patient to do consultative treatment, fusion the ankle or the joint replacement, up to the patient selection and the appropriate of the patient. Next case is an insertion of Achilles tendinopathy. She comes with a chronic heel pain with bumps at the back of the heel. In this case, we do the osteotomy to clear the inflamed bone and soft tissue and reattachment of the Achilles tendon back to the insertion by the special instrument. And after operation, 2 weeks, she can walk with partial weight bearing in walking boot. The next case is a bunion at the inner side of the big toe. First, we do our conservative treatment in our case, at least 6 months. But if it fails, some cases need to do the operation to realign the bone and soft tissue. Oh, sorry. Okay, it's a bunion that I tell. And the next case is a diabetic foot. Diabetic patient came with a diabetic foot with chronic wound. And you can see they have some like a scar, a wound, not healed, at the lateral side of the forefoot. She had a chronic wound, so she cannot walk properly, and previous hospital told her to amputate the foot. In this case, I decided to realignment the ankle and the heel to the neutral alignment, and change the load not only at the lateral side, and with fusion and fixation, we use the locking plate and screw. The next is the plantar heel pain. It's very common problem in the foot and ankle clinic. The differential diagnosis of the plantar heel pain are depend on the mainly location of the pain. History and physical examination will help us to diagnose about 80%. If you have sharp shooting or electrical pain, like some early radiation to the foot, to the toe, and the numbness, so we should think about the spine problem or the nerve problem. But many cases relief from the medication specific to the nerve and no need the surgery to do. And about the consultative treatment in the foot and ankle problem. The consultative treatment and orthopedic device, I choose it the first choice for all patients because everyone knows about the surgery have risks, and the anesthesia risk, I think, is very high. If it's not necessary to do surgery, try the conservative treatment first. What is the deformity? Is anyone know? Yes, this is a bad foot. The arch of foot is collapsed. If I compare to the normal foot, the arch stabilizers is the tibialis posterior tendon, and many arch is in the inner side of the midfoot. So the device to restore the normal foot alignment, we need to push up the medial arch. First is over-the-counter insole. The price is low, easy to buy, but I think it cannot restore all of the deformity of the flat foot, especially in forefoot. Next, I recommend compared to the over-the-counter insole. It is a custom-made insole. The price is a little bit high, but it's fit to your foot. The left picture is the foam, and the middle picture after the patient implants the foot to the foam. We use a plaster cement to establish the shape of foot, and then we do the insole, the custom-made one. And the next is some case need to change not only the insole, but also the entire of the foot. And the below side is the insole, overside is the strap. With the wide shoe room box and soft material coverlet inside the shoe. And for the painful bunion, it's common in aging population. I choose the orthotic for the first choice in our patient. Many types of orthotic used in bunion. We choose different types depending on the problem of the foot. If the problem only in the big toe, we use on the left one. But if the problem is in the big toe and the second toe, maybe we use on the right one. And set to the forefoot pain, I select a silicone pad below the painful point to relieve the pain. And next is an orthotic for the heel pain. The silicone heel cup had a low in patient with plantar heel pain, such as the plantar fasciitis group and the fat hypertrophy. And this slide is very important. The main treatment for the plantar fasciitis, I believe that the cause of the heel pain is come from the tightness in the Achilles tendon. So the stretching exercise gives the patient relief from the plantar fasciitis about 90%, but we take time about 6 months. First step, the Achilles stretching exercise. I use the wall set like in this picture. Your hand touch to the wall about 1 shoulder length. On the back side, you need to stretching here. And the second step for the exercise in the plantar fasciitis is the plantar fasciitis stretching specific exercise. Advise the patient to do like in this picture. By thumb pressure to the arch or the tennis ball rolling below the foot. And the next, about the next topic is about the basic method, how to select your running shoes. First, you need to know that what is your foot alignment. If your foot alignment is neutral, you can use any shoes, normal shoes. But if your foot is supinate, maybe you need some cushion for the supinate foot. But if your foot is overpronation, you need the stabilize to the ankle. Your foot width it means like your foot is big or small. Normally, the result in the D to 2E, you should ask at the cashier, is that okay or not? And the third one is the heel to toe drop. The height of the cushion shoe minus the height of the toe support. If you are a heel strike runner, better use the high drop. But if you are the forefoot strike runner, better use zero drop. to decrease the ground force counter to your ankle. And this part is the last part. This is my specialist, the minimally invasive surgery in foot and ankle. So after I graduated the fellowship in foot and ankle in Thailand, I visited the arthroscopic center in Japan to study non-invasive surgery. So this is the comminuted fracture case. The soft tissue was compromised. And to protect the soft tissue, we need to do the minimally invasive surgery, the small incision and put the plate below the skin. No need to open the fractures. And the next case is a calcaneus fractures. You can see the step here, the big bone here. So nowadays, we know that about the surgery. Surgical wound after we do the open surgery in the heel bone give a complication about 25%. Nowadays, we can choose the non-invasive to the percutaneous screw fixation. And in some type of this one injury, we can choose the percutaneous screw fixation to the better healing and shorter time to do the daily sport. This is a chronic case of the ankle sprain. A 50 years old female runner. She had a chronic pain in the ankle after twisting injury about 5 months ago. She could not jogging. This case, we do an anterior arthroscopy of the ankle to examination and debridement scar fibrotic tissue. And before we percutaneous insert the synthetic ligament for here, the synthetic ligament. So we go inside the ankle by the arthroscopy, debridement of the scar, and debridement for the healing bone and ligament. And the next case, the fusion of the ankle. Nearly all cases, we can do arthroscopic procedure because of the better healing and pain. So this is a new standard for this procedure. Another case after ankle sprain is a cartilage injury. At 6 months, the pain and swelling still off and on after using the ankle in sport. So the diagnosis in this case is a cartilage lesion at the talus. So we decide to do the debridement and microfracture at the lesion. At the same problem, cartilage lesion, but in the other location. In this case, we do the posterior arthroscopic debridement and microfracture for this patient. By the way, it has some limitation to do the arthroscopic in the posterior side because they have many vertebral structure. And I give you a short video for in the chronic plantar fasciitis with a painful calcaneal spur below the foot. If they try to all conservative treatment, but it's still pain. I recommend to do the resection by endoscopic technique. Short video. It's a portal to see inside. First, I do the Achilles lengthening first. You can see the alignment of the foot and ankle is gained. This is the preoperative X-ray with a small. So we go inside, clear the space first. This is the bone spur. We use the burr to cut the bone spur. This is cautery to stop the bleeding. And then you can see still a spur here. This is a plantar fascia. We do some plantar fascia delete in some part at the medial side. And it shows a more spur here. So we cutting, a fine tune cutting. This is about 3 millimeters. after operation, we can cut the spray out and some here. Oh, okay. So this is the last slide. The home message. Take home message is that when to see the doctor for the ankle sprain. If the sprain is about grade 2 or 3, or you have a chronic pain, please come to see the doctor. Self-stretching exercise necessary, as I talked to you. I think most problem in the foot and ankle is come from the too tight of the Achilles tendon and gastrocnemian muscle. Appropriate shoe and activity for your age and your foot. And if you can, we can do minimally invasive procedure. Okay, thank you very much.
I don't have any trouble with my feet, but I play a lot of tennis. Do you recommend getting some custom-made shoe or insole?
It depends on the physical examination, and I think about what is the diagnosis. If you feel pain after you use it too much, it's maybe we should think about first some stress fracture or not, or some torn of the ligament in the foot and ankle. So if you try to change the insole, I think custom-made insole first before we change all of the shoe. I think the insole maybe better.
Okay, Doc. Okay, good presentation. A friend of mine has made a comment that he has some toes that have started to cross over. He didn't specify which ones. Can you kindly comment on why this would happen?
Crossover toe, you mean in the some halak bulgus, right? Some bunion and the
He didn't say, so I just assume he's got a couple of middle toes that have started to move one over the other.
Okay.
So
the crossover toe, we have the problem with it's called a plantar plate. Plantar plate is below the joint of the toe inside, plantar side of the toe. If the plantar plate is disrupted, the toe will going up. That's why it's crossover toe.
okay.
Yeah. Do you recommend any particular brand of shoe? And you probably don't want to endorse anybody, but it's like I probably have 5 or 6 different brands of shoes that I bought and wear them for a month, and they just don't fit me.
Well, it's difficult for me to tell about the brand here because I think any brand fit to everybody, but it cannot fit to you all. One brand cannot fit to you all. In my experience, I have some flat foot a little bit, so I use Skechers. But for the running shoe, I use a Brooks because I think the support is better in some kind of brand. But in the internet, I try to find out about the brand. So many guys review that the ASIC is the best one. I'm not sure about that because I didn't use ASIC. I used Brooks and Skechers.
Doctor, thank you very much for a very interesting lecture. This may not be your cup of tea, maybe on the wrong foot, but I suffer from gout. Is there anything, I mean, I'm having treatment at your hospital for it. Is there anything you can suggest that we can help looking after our feet suffering from gout?
Stop drinking.
From the gout can cause the pain in many joints, but it's most common in the big toe because it's distally, the blood comes distally, and after you stay in some cool weather, the gout crystal, this can produce more. So if you feel pain about the gout, in my opinion, I think take the specific medication for gout first. If it's gout, for sure, not more than 2 days, it will disappear. The pain score from 8 is will below the 2, I think. Take the medication first, and no need to do any massage for gout, because massage is injury more. Shoot legs and take some cold compression, take tablet is enough for gout.
Yes, good morning. I have some neuropathy, it's sort of contained, I think, but also some discomfort on the ball of my foot. Would they be connected or would that be separate?
The neuropathy in the foot is have many problems because the foot is the area that we need to put the weight on. It's weight bearing side. Neuropathy in the foot, first you should see that it's not come from the spine. Second, it's not a diabetes. And then if the foot problem, only foot problem, we can do many treatment like an injection of some anti-inflammatory medication to the neuropathy. But if the neuropathy is not healed, we have many procedures to do about the neuropathy in the foot. Like a tarsal tunnel in the medial side of the ankle or in the toe. Between the toe we have many nerves. It may come from many sides.
Yeah, I understand that, but would the ball of the foot pain discomfort be different than the neuropathy?
About the neuropathy, the pain is, we cannot talk in about what is the pain look like, because the nerve pain may present with many presentation like a numb, or do feel like it's not uncomfortable foot, many pain look like.
Good morning. My question is, what would you do for somebody who has severe chronic pain on the outside of their foot, but nothing shows up on an x-ray, nothing shows up on an MRI, but there has been a diagnosis of a stress fracture that is rubbing on a nerve?
About the chronic pain, first we should do the MRI. But if the MRI is not if the MRI is not show the stress fracture, for real, the MRI will show the stress fracture too, because if you have the stress fracture, MRI will show about like a breathing inside the bone, a small breathing or something like that. But if it's not show, it may be only the small cartilage injury inside, not the pure the stress fractures or the nerve pain, something like that. So I think it depends on the physical examination. I think 80% we can know about the diagnosis from the examination, and the MRI is add-on.
Okay, Doctor. Excuse me. Thank you for your presentation, Doctor. This is just to get back to the individual who was commenting about gout, which is something I wound up suffering from. And you mentioned giving medication is probably one of the best solutions, and I will agree with you, because I had the doctor at your hospital prescribe for me, and I've been taking ever since Colcitex and Puride on a daily basis, and I haven't had any problem with gout since then, except first part of last year when I was in your hospital for 6 weeks, and they stopped giving me the medication, which I complained or screamed, and they promptly reinstituted the medication, and I no longer have the problem with gout. I do recommend the medication because it's been tremendous.
Doctor, I'm thinking more about children here and prevention of foot problems. In Europe, where I come from, children grow up wearing shoes every day, all the time. But here in Asia, I noticed children very often are barefoot. Is one better than the other? Is it a training problem?
I think barefoot is better, sure. Because because of barefoot in my experience, and I think that the original barefoot running is come from, I'm not sure, is in the Asia, right? But when I visit my fellowship in Japan, no one run with barefoot. They recommend to use a running shoe, everybody. I think it depends on your strength of the foot, but I think the shoe will support you.
Okay, Doctor.
Just wanted to ask a question in regards to toes. I'm not sure if it's called hammerhead or something like that. It's when it's elevated and it rubs on your shoe and that. I'm just wondering, is that an easy thing to repair, or how long does it take? Or...
About the hammer toe, we divide the patient into two groups of the hammer toe. The fixed hammer toe, or it's not fixed. If it's not fixed, we can use some orthotic, like a silicone, cover the toe. But if you still feel pain, some operation to the soft tissue is enough. It's not difficult to do it, but it's difficult to diagnose. And if the hammer toe is fixed, fusion of the bone, realignment and fusion of the bone and the toe is recommended.
And how long does that take? Because like the bone rubs on the shoe, and it's like it's just.
Can we remind people, please? I know it's a continuation of what you asked me, but one question.
I wasn't sure.
We're trying to get through.
I'm not sure what he's saying.
But you can probably talk to the doctor later.
Okay.
I'm asking this question on behalf of a very well-known and well-loved club member, but I will have to be discreet and not mention his name. He sent me an email because he is in so much pain from neuropathy in his foot. He wants to know where he can get legalized cannabis.
That might be an open forum question.
Can I not answer this question?
Most of us are aware that the pharmacies here are quite generous in giving out medications. For example, this last week, I got an antibiotic eye drop. I just walked in, he looked at my eye, said, "This is what you need." However, my partner has gout, and when I went to do the same thing at the pharmacy, he said, "My partner's got gout, what does he need?" He said, "I really can't help you there because you need to be evaluated very carefully. So if you do have gout, go to the hospital, see your doctor, and they need to evaluate very closely because there's a lot of different kinds of medications that will be helpful, a lot of medications that will not be helpful. So don't try to go to the pharmacy on your own if you have gout because they will not give you something."
Could you tell us a little bit about where your patients come from? And I do want to ask a question a little bit on, do you have any patients who have come from Indochina that they've had, that they need foot surgery from, what am I talking about, the little bombs that go off on their foot?
China?
No, from like Laos maybe, or Vietnam, or maybe Cambodia? Or possibly Myanmar.
The nationality of the patient? Mainly Thai. And second is US. About the number of patients.
Well, I thought your talk was really well done and really informative. Thank you. And you can see from the number of questions that it's an issue for a lot of people. I have orthotics, which I'm really glad I got, and custom made. And I was very interested, the guy was saying that he really wasn't in favour of arch supports because he felt they weren't natural, and some flat-footed people need them. And he was also against this whole idea of buying shoes with built-in arch supports, because that sort of forces you into an arch support that might not be right for your foot. So I wonder what your stand is on built-in arch supports on running shoes, etc.
About the arch support, in another patient, the other patient, not the same arch support. Some patient need only 4 millimeters. Some patient need 1 centimeter. But I think that the built-in arch support is okay if you use this shoe many times. But in some patients, they use only about 1 or 2 hours. You can change your insole to many shoes if you do only the insole.
Doctor, good lecture. Can we explain the difference between a strain and a sprain? We are quite...
Okay, about the strain and sprain.
Sprain and strain.
We talk about the strain we use with the muscle. We use with the muscle, the red muscle, the red one. But the muscle at the insertion or the origin is a tendon. This is tendon. When the tendon is injury, we call it sprain. Tendon is sprain. Muscle is a strain. Strain. Muscle strain. Ankle is tendon. So ankle sprain.
What about strain?
It showed you a strain.
I can take it. You're talking about constant pain from a strain or sprain. How long should you go before you see a doctor?
Normally, I advise the patient about the acute sprain and chronic sprain.
Yeah, the chronic.
3 months. I cut up at 3 months. The ability to healing of the tendon by itself, it should within 3 months. After that, I think it cannot.
Just a minute.
My second question.
Where can I get a custom-made insole?
It's very hard to tell. In our hospital, we have the department for it.
Any more questions? No? Okay, thank you, Doctor.